So here are some basic few ones. So we'll start with nose and then we'll do ear. Okay. So on nose right now we have three practical situations and the questions associated with it. What is this? Epistaxis. So what is epistaxis?
Bleeding from nose.
Any bleeding from nose is epistaxis. Okay. So first questions asked from this is, what are the commonest causes of epistaxis? So I would suggest whenever a question like this is asked, please divide in age groups. Okay, kids, young adults or adults, and elderly patients. So it becomes easier, and you also will be able to, remember the disease as well. So when we are talking of kids, the commonest cause is trauma. Any trauma. It can be a finger pricking or it can be an external trauma, like the kid is just playing outside, got a trauma. Second, kid, yeah, polyp is important. We'll come to polyp, but before that, something very important. Not very common, but very important. Foreign body can cause epistaxis, but it's a very late presentation. Genetic disorders, hereditary disorders, bleeding diastasis. ঠিক আছে? or a hemophilia patient. Okay. So many other causes of hereditary. Don't ask me, just kidding. Hereditary hemorrhagic disorders can cause bleeding. Then comes okay. Sir, bosun sir. Sir, এদিকে আসবেন sir, please. Basic courtesy. Very good. নেতা 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 না নেতা না একই রে তাহলে তো কাজ করতে সাহস পাবে আচ্ছা দেন এখানে চলে আসুন others foreign body someone said foreign body so old neglected foreign body can cause local inflammatory reactions and cause epistaxis okay others polyp ke bolchilo okay. So infected nasal polyps enteroconal polyps are very common in children right so enteroconal polyps have seen patients not seen okay so it's basically a polypoidal changes of the middle meters and arising from the maxillary antrum is enteroconal and goes towards the choana. Why does it go towards the choana and not come outside? Because the flow of air is from anterior to posterior, so it usually tends to go posterior along the flow of the air. Okay. Okay. Then come adults. Adults then again first important cause is trauma, very common. Hypertension will come in elderly. Okay. Yeah, that one is very important. So it's young adults. Adolescent males, not adults, adolescent males can have a condition called juvenile nasopharyngeal angiofibroma. We call it a JNA. Okay. Male patient, adolescent patient can have a condition. It's kind of a tumor of the blood vascular. And there are a lot of theories also. We will go through it. We will do it in a theory class, explain in details. So it's basically a tumor of the blood vessels, which can cause severe recurrent episodes of severe epistaxis in adolescent male patient. It does not occur in females and does not occur in adults, only adolescent age group. We have seen patients from the age of 6 years, 6-7 years till 13-14 years. Commonest and sometimes neglected to 15-16 years. But this is the commonest age group of presentation. Okay? Painless recurrent epistaxis. Basically, it's a kind of a tumor which arises near the pterygoid plates. Okay, and it can come into the nasal cavity or it can go into the infratemporal fossa also. We'll explain in details in a theory class. So, then elderly hypertension is one of the commonest cause in elderly people, But what is the difference between an hypertensive epistaxis and say a traumatic epistaxis or any other arterial epistaxis? Hypertensive epistaxis कोते है? Where does it occur from? A fingernail pricking causing epistaxis is an anterior epistaxis. It's from the which area? What is it called? Little's area. So what are the vessels?
Anteethmoidal, posterior superior labial,
Posterior lacena, anterior superior labial, sphenopalatine. Superior labial, बोल लीजिए. Posterior ethmoidal usually doesn't come into the little area because posterior ethmoidal is much more posterior and little area is very anterior. It's anterior part of the septum. Okay, there is a commonest place where the children prick. Hypotensive epistaxis occurs from which plexus? It's called a venous plexus. It's called the Woodruff's plexus. It's the posterior area, posterior part of the nose. Okay, so if you see one nasal endoscopy, you'll be able to understand very easily. So there are three passes. We go first to the inferior meatus to see the nasal airway. We see the nasopharynx. Then we go to the middle meatus, and lastly we go in the sphenopalatine region and the posterior Woodruff's area. So just behind the posterior wall of maxillary sinus, we have the internal maxillary artery coming in and gives us sphenopalatine branch. Right? You know this or not? This is anatomy knowledge from first year. Maxilla, maxillary antrum. Okay. This is the nose. Maxillary antrum here. Okay. So there is a posterior wall. So there is the anterolateral wall, the medial wall, and the posterior wall. Maxilla has three walls, you know, remember, right? So maxilla has three walls, okay? One is the anterolateral wall, the medial wall is towards the nasal cavity, and the posterior wall. Okay? So behind the posterior wall, the internal maxillary, what is external maxillary artery? Anyone knows? Very commonly asked questions in Viva. What is external maxillary artery? Or which one is external maxillary artery? Facial artery is called external maxillary artery. Okay. I was asked about the course of external maxillary artery, I could not answer. So this internal maxillary artery comes, so there is a sphenopalatine branch. So all of this thing is happening behind the posterior wall of the maxillary sinus. So we have the pterygopalatine fossa. It's difficult to explain. So from behind the maxillary antral wall, this artery comes and enters the nasal cavity. Okay. So this area, say, so maxillary antrum, say it is like a cube. Okay. So this is the medial wall. And on the medial wall what we have? We have the inferior turbinate. Right? Inferior turbinate we have on the medial wall of the maxillary, lateral wall of the nasal cavity. So here is the septum. Okay. So this is the posterior end of the inferior turbinate. So just behind the posterior end of the interior turbinate, these vessels should come out like this because it's coming from behind the maxilla. Maxilla you can understand, right? This is the maxillary antrum, there is a space, the three-dimensional space. From behind the maxillary antrum is coming, the vessels are coming. It's entering the nasal cavity like this, and that happens to be behind the posterior end of the inferior turbinate as well. Did you understand or not? It is important. We have the choana over here, the posterior end of the nasal cavity, the posterior part of the nasal cavity. The sphenopalatine artery comes and gives branches. So this is another common site of epistaxis, particularly iatrogenic, post-surgery, post-endoscopic sinus surgeries or post say maxillary enterostomies can have this bleeding. So we sometimes do something called an ESPAL, endoscopic sphenopalatine artery ligation. Okay? So sometimes it is required of uncontrolled epistaxis, severe uncontrolled epistaxis, we may have to do it. এটা বুঝতে পেরেছিস ক্যামেরা ভিতরে বুঝতে পারিসনি? If I had a skull, it would have been easier, but then again we don't have it right now. Acha, then what is, so these are the commonest causes of epistaxis. So there are multiple thousands other chronic disorders, all chronic diseases can have epistaxis, debilitated patient, even in hemorrhagic fevers like dengue, where there is low platelet count. Any condition with low platelet count can give rise to epistaxis, like granulocytosis, anything. So many conditions. So, what is your management? Nasal packing. Okay. Yeah. So first we'll try with. So we'll try to understand what the cause is. It is important. Why? Because usually a traumatic epistaxis stops on its own. It will bleed for a few times, but gradually it stops on its own because the patient is normal otherwise. It was just a trauma. So his coagulation profile is most likely normal. Okay. So there is more chance that the bleeding will stop by the body's natural mechanism. Okay. On the other hand, a hypertensive patient, say, is having repeated epistaxis because of the hypertension. So until and unless we correct the hypertension, the epistaxis will go on. So this patient is diseased. Both are different. Okay. So for this patient, till the blood pressure comes down, we have to do something to stop the bleeding. Otherwise, there will be massive blood loss. So first we do something called what maneuver is this called? Hypocrite maneuver. So we hold just below the nasal bone. We pinch very tightly, just below the nasal bone, and at least for 10 to 12 minutes, we keep it pinched hard, so that there is clotting of blood, this formation of blood clot, and stoppage of active epistaxis first. So now that we cannot, even after doing pinching for multiple times, we are not able to stop it. The next step is nasal packing. So it's called an anterior nasal packing. So there are two different things: anterior nasal packing and posterior nasal packing. So what is anterior nasal packing? So this is a picture of a anterior nasal pack. আমাকে তোদের পরীক্ষায় someone told me maggots. এটা দেখে আমাকে ম্যাগট বলেছে। Seriously বলছে, I'm not joking. Somebody told me this is a picture of nasal maggots. So the quality of picture is bad, but not as bad. Okay. So try to identify one thing. When we start packing the nose, it's usually in layers. So see, nose is nothing like an open room. It's not like that. It's a lot of structures inside. We have the turbinates coming in, the septum may have a deviation, there can be a middle turbinate dropping in. So many structures. And these bleedings usually occur from the crevices. একদম বাইরে থেকে middle turbinate মাথা থেকে বিট করছে এরকম তো হয় না. Usually from some vessels in some of the crevices. Okay. So we don't know where it is bleeding from. When we are packing the nose, try to understand, when we are packing the nose, we never know where the bleeding is coming from because it is too much to identify. That's why we are packing it, stopping it temporarily, and then we'll plan on removing the pack at a later date and identify the source of bleeding. Okay. So it has to be in layers. So what instruments are used for nasal packing? It's called a nasal pack. Don't say gauze, it's called a nasal pack. It's a contact. Gauze is a specific strip. Okay, so the nasal pack and instrument I'm asking. What is the forceps called? Krishna Gopal, our instrument box ta khuniya. What is the instrument called? Opening the instrument box ta ache tune daw. Anyone heard of Tilly's forceps? Huh? And a nasal speculum. So you need to open the nose wide, put the pack in, and it has to be in layers. So first the inferior most layer, then we'll put, so the pack is like that, so you hold in middle, put the first layer, and it has to be parallel to the palate. নাক কিন্তু এরকম নয়, the nose is like this, we cannot go in like this, এরকম ভাবে প্যাক দেওয়া হয় না, you have to go in, and so the forceps looks like this. Hello, hello, পরে ফোন করো প্লিজ, ক্লাস নিচ্ছি। Okay, the forceps looks like this only. Can I say? Hello? I don't know what to use forceps. So I've seen a heart convertilis forceps, na? Boy খুলে দেখবি, so it looks like this. So we can just hold this, open up, it looks different, I know. So ignore that. So the forceps is like this, the two prongs. We hold the pack in between, put it in, take out, then again take another one in, and so in layers we put it. Okay. So we give pressure, and when there is epistaxis, we always do bilateral nasal packing. Why? What is the role of bilateral? Even if it is bleeding from one side, we do a bilateral nasal packing. Why? This is for pressure, because see, the septum is a cartilaginous structure. Septum is mostly cartilaginous, it's not bony. So if we put the pack in there, just it may force the septum to bulge to the opposite side, and the pressure will not be adequate. So if we pack on both sides, so it will keep the septum in midline and will give adequate pressure. Okay. Then still not controlled. What is the next step? Posterior packing. There is something called a posterior nasal packing. What is the next step? Still not controlled even after this. That is the last step. That is the final procedure. So we do something called a posterior nasal packing. So how we do a posterior nasal packing? So क्या করবি? ঠিকই বলছিস। কিভাবে করবি? মুখ দিয়ে আগে ঢোকাবো? নাক দিয়ে কি ঢোকাবো? নাক দিয়ে প্যাকটা ঢোকাবো? See, the idea is, try to understand. Say, like I said, this is the nose. Huh? So the choana is this big. Choana is small. Choana কিন্তু পুরো নাকটা জুড়ে choana হয় না. So our idea is, and this is the nasopharynx. So our idea is to put something over here to block the choana. Now the anterior pack you have already given. The patient will bleed posteriorly. You have to put something in here. So it should be big enough not to pass through the choana. So if we put it through the nose, will we be able to go here? No. So we have to put it through the mouth. Right? This part is clear? So what we do is, we introduce a catheter or something from the nose. Okay? It can be a rubber catheter, or it can be a guide. Nowadays we have that soft silastic catheters. So we put it in the nasopharynx. Then open the mouth, insert a forceps and take this thing out through the mouth. বুঝতে পেরেছিস? Then attach the pack over here, and then gradually pull it. So once it goes to the nasopharynx, we usually use a finger to negotiate it behind the palate. Because এখানে প্যালেটটা compress হয়ে যায়, we usually negotiate it behind the palate and put it there. So another thing that can be used very commonly is a Foley catheter. You have seen a Foley catheter, right? Foley's catheter you have already seen. So we introduce the Foley catheter to the nose directly. Then when in the pharynx, we put air. Instead of water, we put air. Why do we put air instead of water? You have seen a Foley catheter. It has a bulb, right? So we can inject something to inflate the bulb. So we put the catheter over here. When it comes to pharynx, we inflate the bulb and then put it in the corner. This works same as the posterior nasal bag. There are two ways. But we always, instead of when you are doing a catheter, like urinary catheter, we are using water. Right? But when doing this thing, we are using air. Why? Because by chance if the bulb bursts, the patient will not aspirate. Visible? There will be air inside, the patient will not aspirate. That is the idea. Okay? Next step, even if not controlled after that, then cauterization or doing a nasal endoscopy. So it is very difficult to do a nasal endoscopy in a very actively bleeding nose, not controlled by nasal pack. Because it is extremely difficult. Okay. But still sometimes we have to do when there is a very severe bleeding from somewhere. These small things if you see, the small sources of bleeding, like say little area small bleeds, they can chemically cauterize it or electrocauterize that area and it stops. No big. Major bleedings from sphenopalatine artery, we do something called the endoscopic sphenopalatine artery ligation. ESPAL. ESPAL, endoscopic sphenopalatine artery ligation. Okay. When not controlled after that. কি করে করবি? চলে রিভাস্কুলারাইজ কেন করবি? রিভাস্কুলারাইজ তো করতে চাস না, তুই তো ব্লিডিং বন্ধ করতে চাস, কি করবি? ভেরি ক্লোজ। ফেসিয়াল আর্টারি কি আছে? ফেসিয়াল আর্টারি একমাত্র সেপ্টাল আর্টারি আছে, যেটা two things. First is you can take help of intervention radiology to embolize the vessel. Or second, you can do a external carotid ligation. If you common carotid ligate kori, you will have a stroke. Epistaxis বন্ধ করতে গিয়ে stroke হয়ে যায় patient. So never. External carotid ligation. Why? External carotid are all superficial branches. So it doesn't matter. Multiple times you will do it in your life. If you do ENT, multiple times you will do in your life. External carotid ligation. Okay? So that is the last resort that we do. But sadly, nose is one of those places is supplied both by internal carotid and external carotid. Ethmoidal arteries gulo kisher branch? এই না বলতে পারি আমি এটা শুনে মারব। Ethmoidal arteries are branches of Google করবি নাকি? হ্যাঁ? তার ব্রাঞ্চ Sphenopalatine artery is a branch of maxillary artery. Ethmoidal artery is a branch of ophthalmic artery, which is a branch of internal carotid artery. So nose has branches of both external and internal carotid arteries. So even if you ligate external carotid artery, there is still a possibility that the patient may still continue to bleed, but you cannot do anything to it unless you go ahead and do a IR, intervention radiology intervention, and embolize that particular vessel going through internal carotid. Okay? So lot of things about epistaxis. Now we will go with this one. What is this? This is a CT scan. What are the cuts? What is this cut called? What is this cut called? What are the Three types of cuts.
Sagittal.
Axial. So cutting like this is axial. Okay. Cutting like this is sagittal. And cutting like this is coronal. So this is a coronal cut. It's cut like this. And this one is axial cut. Okay. So normally we nose and paranasal sinus CT scans, we go ahead with axial and coronal cuts with sagittal reconstructions if required. So axial and coronal cuts are important. Okay. So what do we see over here? Polyp sure. Air to edike ache, that is normal. Sinus has air, that is normal. Never say polyp directly. Say it's a homogeneous opacity involving the maxillary sinus and the ethmoidal sinus of the, which side is this?
Left side.
That is left side. So the patient is facing towards you. In CT scan, always take that the patient is facing towards you. So this is the left side. Okay. So there is a homogeneous opacity involving the nasal cavity, the maxillary sinus, the left ethmoidal sinuses. Okay. So the examiner will ask you, okay, and there is deviated nasal septum probably due to mass effect of the pathology, causing deviation of the nasal septum to the opposite side. Okay. Then comes what are the differential diagnosis. You never go in with polyp directly. Never say polyp directly at first. Say homogeneous opacity, then when it comes to DD, then you say nasal polyp. So it can be a nasal polyp. Okay. So what are the commonest nasal polyps that you have? Polyp number, maxillary is the location. Antroconal polyp, ethmoidal polyps. What is the difference between these two? Unilateral, bilateral. Allergic origin, infectious origin, very good. Age distribution, very good. So these are the three most important differentials between ethmoidal polyp and antroconal polyp, and obviously the location that you know. One comes from the maxillary antrum, comes out to the choana and to the maxillary and ostium and goes towards the choana. And the other is strictly first involving the ethmoidal area, and then later on it comes. Many ethmoidal sinus patients we see only involving the nasal cavity and the ethmoidal cell, not going to the maxillary antrum. It's very common to see. Okay? So, what are the other causes apart from nasal polyps that can present like this? Huh? Other causes of this opacity. Sinusitis. Achha. See, the difference between sinusitis and polyp is sinusitis is an active infection, right? So we are not talking of chronic sinusitis. Chronic sinusitis only presents with thickening. Say this is the maxillary antrum though, so it looks like this though. If this is the nose, so in maxillary antrum there will be only mucosal thickening, so it will look like this. Air in between. So that is a chronic sinusitis kind of feature. Acute sinusitis can present like this, but then again this much of homogeneous opacity unlikely to be maxillary sinusitis. You can keep it in the DD, but this is a maxillary along with ethmoidal sinusitis. So this area is a ethmoidal sinus, medial to the orbit. The lower down, this is the maxillary sinus, and this part is the nasal cavity. We cannot see the sphenoid sinus is here. So the sphenoid sinus is also involved in this case. So what is the treatment? Say this is a polyp. What are the other DDs? Other differential diagnosis. Well, elderly patients, what are common? Any nasal tumors can present like this. It can be a inverted papilloma. It can be a sinonasal malignancy. It can be a fungal sinusitis. Okay. So many differential diagnoses. Start with the most benign and the common things first, and then gradually go up. Okay, so what will be the plan of management? Obviously, you have done a CT scan, you have identified this, and this is what? This is an antroconal polyp. See, this is typically the middle turbinate, and the polypoidal tissue is in the middle meatus. So it is definitely coming from the maxillary sinus, most likely. Extravehicular sinus second, it's going towards the choana, posteriorly. বুঝতে পেরেছিস না বুঝতে পারিসনি? Is a polypoidal tissue coming out going towards the choana, towards the posterior end of the nasal cavity. So this is the antroconal polyp, and you can typically see this polypoidal things connected by this attachment. This was the case of antroconal polyp probably, and a functional endoscopic sinus surgery is done and the polyp is removed. What if it doesn't look like a polyp? Say this opacity is heterogeneous. It's not as homogeneous. See, polyps will usually have a very homogeneous opacity, right? Because it's just edema. Polypoidal changes, edema of the mucosa, nothing else, right? But if it has a heterogeneous opacity, what are the differential diagnoses? Tumors, inverted papillomas, malignancies, and fungal sinusitis will have a very heterogeneous appearance. Okay, so when they ask you about heterogeneous opacities, fungal sinusitis 1, then malignancies. For inverted papilloma and then malignancies. So these are the DDs. Okay. বলো ট্রিটমেন্ট কি করবি? Functional endoscopic sinus surgery. Is there any role of conservative treatment? Steroid has limited role in AC polyps, but for ethmoidal polyps, steroid has a very important role because it's allergic origin. So, if it's an ethmoidal polyp, go for conservative management first. Basically, this one is severe one, so usually doesn't present this late. If it is like limited polypoidal tissue, we go for conservative treatments with steroid nasal sprays. We start with intranasal corticosteroids, not injections. These are steroid nasal sprays. These are topically acting. So what does it do? It decreases the polypoidal changes since it's a steroid with minimal absorption in the bloodstream, so minimal systemic side effects. First. Second option is to go for systemic corticosteroids like prednisolone or methylprednisolone tablets, 1 mg per kg body weight. We usually start sometimes when it is very extensive and INCS cannot work properly. Okay, so we have to sometimes give oral steroids as well. Okay, alright. 1 mg per kg, 2 mg per kg depends on severity of the disease, the comorbidity associated, the age of the patient, lot of things. But usually 1 mg per kg is safe. So if they ask you, say 1 mg per kg. So that is the safest. আচ্ছা, এখানে আরেকটা নাক থেকে আরেকটা জিনিস. Oh, what is this thing? Can anyone tell me? Oh, very good. Orbital cellulitis. What is it? What is it? What is orbital cellulitis? What is orbital cellulitis? Inflammation of the orbit caused by obviously bacteria. Cellulitis তো আমি গিয়ে কজ করবো না, দেখে তো একটা ব্যাকটেরিয়া থেকে হয়েছে. Is usually a complication of a pansinusitis or a severe sinusitis. Any form of aggressive sinusitis can complicate as a orbital cellulitis. So what is the treatment? Never say steroids first, because steroids decrease the local immunity. It's a severe infection, it will flare up. It's an infection. Understand the difference between the other. Ethmoidal polyp is not an infectious disease, it's an allergic disease. That's why we are using steroids. Here we will use steroids, the coverage of antibiotics, and we'll try to drain the pus. Once there is gross inflammation of the orbit, we'll have to enter the orbit, open up spaces, drain the collection and the pus, Otherwise, we will not be able to save the eye. We all have seen people go blind with overhead cellulitis. Once rarely in your lifetime you will see maybe 2-3 patients. Most of them will go blind. If not, because they come from villages and distant places, they won't access healthcare immediately. They will come near half blind. So even after doing surgeries, it probably will not be always able to save vision. But it's very rewarding. If I can do it in time, it's very rewarding. Okay. So this one is today morning I was taking class in the OPD. I was showing this. So this is a merosil. This is a self-expanding nasal pack. So just put it in the nose, it expands. And you have to remove it after 2 to 4 days. Okay, so if they ask you, so it's a self-expanding nasal pack. Okay, ready-made nasal pack. And this is the posterior Foley catheter for a posterior nasal pack. Okay, they will ask you why. This is cauterization of the bleeding point. And this is the intranasal packing, like I said, going layer by layer.